Great deal, great pleasure, great pleasure. Nice to see you again as always. Dr. Bushra Anwar is a public health fellow of the College of Physicians and Surgeons, Pakistan, and holds a certification in clinical research from McMaster University, Canada. Very well done. She leads public health startups in Pakistan and Canada dedicated to reducing global health disparities and strengthening health system resilience. As director of an international research training program, she mentors students in healthcare innovation and basic research. An active member of the Association of Pakistani Physicians in Canada and Public Health Networks in Pakistan, Dr. Anwar continues to champion initiatives that build healthcare capacity and advance community well-being across borders. Let's welcome Dr. Bushra Anwar.
Good afternoon, everyone, and thank you for joining us here. We'll discuss what are the challenges, what we can advocate for, and why the world needs to support. My insights are drawn from published literature as well as some informal interviews with colleagues who worked in polio program in Pakistan, and I have no conflicts of interest to declare. What we see now is a public health paradox. What is that? As we get closer to zero, the fight becomes harder. Why? Because the public no longer receives the same level of threat and their support can wane. This makes our fight even harder. And I will discuss the final barriers that we now face under 3 categories. This we discussed last time too, the program design, the system itself, and the people. And I'll discuss in all these categories what are the new developments that I have observed in these 6 months. So let's start with the program design and leadership. That's the biggest thing that is flawed. There has always been lack of government ownership and extreme reliance on donors. That led to role confusion. There are executive structures for polio in place, but those are perceived as ineffective, and our district health officers remain overburdened. There is top-down approach in this program. Those who are working on ground and the frontline workers are not heard. The community's voice is not included. There is lack of synergy with routine immunization, and this comes across as a program that diverts a lot of focus on just one disease and disrupts our routine immunization oftentimes during the campaigns. On the top of that, we have been relying on outdated methods. You can see this picture. This is a handwritten map. It was published by my friend this year, and she highlighted how we are not using the latest technology in this program. But thankfully, we are seeing good changes. Since the last campaign, for the last 6 months, they have started using the geographic information system mapping in the campaigns, which is a good thing because it helped our teams estimate the houses right, and this helped reduce the vaccine wastage. Also, that some of the technology is being added at the level of team at area in charges, where they can record the location of the teams and prevent fake reporting. Since last month, there have been funding shifts. There are funding cuts for Pakistan, and we can hope that political will is increasing. As the program adapts, our systemic challenges remain immense. We have some high-risk areas in the north and south of Pakistan where we have high-density population, frequent mass movement, refugees coming in, and with underlying high rates of malnutrition and inadequate sanitation, all of which are indicators of polio transmission. And logistical difficulties are a nightmare. We have remote terrain and cross-border transmission, and then we have severe security issues and attacks on our teams that sometimes leads to worker strikes. Then poor infrastructure leads to electrical supply shortages, which affect the cold chain and makes the vaccine ineffective in some areas. And add to this a new layer of disasters. So this year we had mass floods that disrupted everything that we do. This brings us to the most critical aspect, that is our community response. Our communities are now facing campaign fatigue. And when their basic needs are not met, they show hostility towards a program that creates hype for just one disease, while their children are having other diseases more commonly, having diarrheas, malnutrition. So this leads to the political bargaining. They use this program then for bargaining with politicians for their basic needs, like roads construction also sometimes. There is mistrust with the vaccine because not just because they have been linking it with Western conspiracy, but because now they have seen the COVID-19 vaccine conspiracy theories also coming from the West. So these anti-vaccine narratives coming from the West, they have also shifted the narratives, and this mistrust has now further evolved to more vaccines. In some conservative regions, there are cultural resistance also, because they don't allow the male vaccinators to come inside home, and the female teams are scarce in those conservative regions. And the most difficult thing is hiding children. And this is happening in the north of Pakistan. And this is due to gender insecurity fears. And this is something very challenging in the north, where we have most of the cases this year. So we have observed some positive changes in leadership, and there were more complications in the system and people. But the most important change in all of these three, I believe, in my opinion, it is the leadership. Because system you cannot fix. If your political will is increasing, your leadership is improving, that's a very good sign, because that will bring ownership in the people also, in partnership with people. So as we get hope, we can, our donors can advocate for some good changes at this time. I think now is a very good time where donors can also start building ownership with our leadership, with our government. What's happening in the past was the third parties were outsourced to operate in Pakistan, and government was not taking ownership. So I think the solution is a partnership, two-sided ownership, where donors can take the start, build the trust with the government, and this will lead to a genuine ownership by our government. And when our government and our leaders will own it, this will inspire leadership in our own people also. When they will see their own leaders owning this, and becoming the face of program, their cooperation will naturally follow. And when we have the right leadership in place, we can further talk about improving the program design, both on ethical fronts and technical fronts. Now, ethics. Ethics is not a fancy concept, it's not a bookish thing and something not practical. It is something very important. Ethics is the gateway to building trust, and trust is the currency in public health. When people see your program as ethical and beneficial, they start cooperating. Our benefits have to be more than the risks. This has to be perceived by the public. Respect, which is something mandatory, it has remained missing. We have used coercive approaches to meet our vaccination targets. This actually broke the trust of public, and they started showing resistance in long term. And now we see this resistance, refusals more commonly happening. Then, justice is not perceived. Our frontline workers take their risk. They are at risk of being killed in Pakistan because there is anti-polio narrative also. So our workers are killed often, and they are taking this risk. You know, for how much payment? Just it's around $3 per day. And while those on the top of program are perceived to live in luxury. And these risks, they are not fairly distributed. These risks that the frontline teams are facing, these are among only the vulnerable groups, you know, because those who are often less educated or from low middle income families, they join these frontline teams, and our risks are borne by them. So this is then, this creates a perception of lack of fairness and lack of justice in the program. Then transparency and accountability was not strong. And why? Because there was role confusion. There was confusion of authority. And the responsibilities were blurred, transparency was blurred, accountability was blurred. All of this creates a negative image of the program, which needs to be fixed, because ethical standards were not there in the program design, and ethical standards are not there in the accountability framework of this program. So while we fix the ethics, we need to improve some technical aspects also. Many of our top public health experts of Pakistan have often advocated for integrating this program with routine immunization. And this is in line with WHO's own frameworks also. WHO has published these, you can see, integrated people-centered care framework. So WHO also advocates for shifting focus from disease-specific programs to integrated care, and that is centered around people, empowering communities to own their care. We need to improve the operational efficiency of programs also, adding more technology, and we have some smartphones given to area in charges, but not to the frontline teams. We need that because that will help us with many things, especially the fake reporting. One of the biggest mistakes in the past that we have done was handling refusals non-technically, non-ethically. So we have used these kind of ways like jail, you will be jailed, your SIM will be blocked, you will be having, your ID cards will be blocked. These kind of methods are actually non-technical in health programs. And because this program was not in the hands of technical people. It was in the hands of administration teams, and those people are not trained for handling refusals and these kind of things. So this was not only unethical, it was non-technical. And we have better frameworks now. We have to address these refusals technically, ethically, using scientific guidance. Now coming to the last point. Why the world needs to support? Why should we care? It's a thing in Pakistan or Afghanistan, but why should we care? So actually, the math is terrifying. This program, though it was very successful in reducing cases from 350,000 cases in 1988 to just a few now, and from 125 endemic countries to 2 now. But if we stop this, there will be 200,000 new cases every year. And the cost of that would be, in low-income countries, it will be a few hundreds, and in our countries, in Americas, it will be in thousands. So this is 31,000 was calculated many years back. It will be way above than this per case cost. And let's be blunt, our WHO former researchers stated that we have spent more than $1 billion in the last 5 years in Pakistan alone, and it didn't buy us any progress. So was our model broken? What should have been the path? Was this a case of for our funding from Ministry of Health, Pakistan, to fund alone? Our cost-benefit analysis shows that the cost is higher than the benefits, societal benefits gained. And so this does not justify the funding from Pakistan alone. And this is the case in global disease eradication programs, because the rewards are global. It is global public good. And while the risks are local and benefits appear less locally, the rewards are shared globally. And this is why equitable funding from all countries, not just West or East, from all countries, it should be pooled in some global health security fund. It's then a shared responsibility, not a charity. And it is the true partnership. and it should come with strong accountability. And this should be grounded in collaboration, guided by the principles that we have discussed. What we need worker safety and fair compensation plans to reduce the risks in our communities. We need Polio Plus strategy to increase the community benefits. You know, Polio Plus is the strategy that helped Nigeria also finish the job. In Polio Plus, you do not just bring one vaccine, polio, you bring it as a package of health service. This increases the benefit for the community, and they will also be more likely to accept your service. And that will help us finish the job quicker. And lastly, we need care for our vulnerable populations with integrity. They should be heard, and they should have some channels for feedback. They should be having some channels for accountability. So now I invite you all to be the one who speaks up for change and to ensure that our program not only achieves its goals, but it does that with integrity. And remember, your voice matters. As donors, we have influence and we will be heard. And because our people were not heard, so I want to make them heard. I want to show you some images and in a video to honor their sacrifice and acknowledge their efforts. This is how our people work on ground. This is the human cost of our mission. Let's honor them. Let's speak up for their rights. Let's support. Thank you so much.
Well, thank you so much, Dr. Anwar. Great update. So, just a couple of things. You touched on ethics. There's a few realtors in the room. We have to do an ethic upgrade every year. And along that line, it would be nice to see, it would be nice to know that the money we're sending over there is being used responsibly. When you donate to Rotary, you know that there's a team of people thinking about how that money is going to be used and what is going to happen at the other end of at the other end. So a good reason to donate through Rotary. Let's see, you touched on the technical aspects of getting the job done. So they're working hard in Pakistan to make it happen.